All right, welcome everyone. You are joining us on April 30th, 2024 at 2 p.m. Eastern Time for part 6, or the final part of our Medical Legal Partnership in Action webinar series. Today's topic covers advancing health equity for patients impacted by the criminal justice system. And you're joining the National Center for Medical Legal Partnership. We're based at the George Washington University. Welcome. Let's go to the next slide. I am Bethany Hamilton, Director of the National Center for Medical Legal Partnership. Today, I will be serving just the moderator with some brief introductory remarks as well as some announcements. Let's go to the next slide. This entire webinar series has been funded by the Health Resources and Services Administration, or HRSA. The National Center for Medical Legal Partnership is actually in its 10th year as a training and technical assistance partner to HRSA, providing resources and support primarily to health centers under this grant for ensuring that they are able to implement MLP strategies as well as MLP in their in their ability, to serve the patient populations with their health-related social needs. So thank you to HRSA. Just some brief housekeeping next. So as you can see on this housekeeping slide, we are utilizing the Q&A panel in Zoom. So if you go into the Zoom pane and select Q&A, that's where we'll be paying the most attention to any questions that come in, but folks are also welcome to and encouraged to use the chat if they want to share comments, or if the Q&A pane doesn't work for some reason, you're welcome to use the chat. If you do need any assistance, do use the chat to send a message to us as hosts and panelists so that we can assist you. And also, if you need to use the caption, select live transcript and show subtitle so that the captions in Zoom can show up. This webinar will be recorded, and the slides as well as the archive of the recording will be shared on the Medical Legal Partnership website. There's a page for this entire MLP in Action webinar series. Okay, so for today's webinar, we have some learning objectives that we're aiming to achieve for the entire audience today. Number one, as a part of this entire webinar series, we're hoping that we can help the audience members strengthen their cultural competency to effectively serve really diverse populations. We're also hoping to help the audience expand their comprehension of how medical legal partnerships in particular can enhance a healthcare delivery model for specific demographic groups. And finally, we're hoping to help you identify opportunities to implement improved strategies for both screening and addressing social risk factors that affect the health of patients involved in the criminal justice system. Right, let's go to the next slide. On this slide, we want to call out or call to your attention, if you will, a serendipitously announced funding opportunity that came out recently, as it is Second Chance Month. So if folks see in this slide, as a part of the White House Second Chance Initiative, HRSA is actually offering a brand new funding opportunity to health centers to provide really crucial health services that are needed for those who are transitioning out of incarceration. The funding opportunity focuses on primary care, mental health, and substance abuse treatment, and approximately 51 health centers will receive funding to implement strategies that address reducing drug overdose risk, managing chronic conditions, preventing and treating infectious diseases, and addressing mental health and substance abuse treatment needs. The applications for this new funding opportunity are due on June 10th. And as you know, in the federal grant funding space, that deadline will come very quickly. So we encourage folks who are interested in this opportunity to take a look at the grants.gov website to learn more about this opportunity, how to bring together a successful application. Embedded in the slide deck will be the links to the funding opportunity. And Rahal has also plugged a link to our website where you'll find the archives of today's event, and we'll certainly add more information about the funding opportunity to the MLP update as well as to our website. Let's go to the next slide with the next announcement. Folks may have also seen during Second Chance Month that the Department of Justice announced a really groundbreaking new medical legal partnership collaboration that they'll be piloting with Texas A&M School of Law and Texas A&M's Institute for Healthcare Access. So DOJ's Office for Access to Justice and the Federal Bureau of Prisons will be piloting an opportunity with Texas A&M to really address the Social Security or disability benefits needs of our incarcerees. And they've selected a specific federal prison to work with to plan out and develop this pilot. And we would encourage folks to keep an eye on how this opportunity presents an example or case study for us to really grow how we or expand our definition of medical legal partnership and the opportunities to partner with different types of entities, such as federal agencies. Um, all right. And in this slide, by the way, we've also linked to Acting Associate Attorney General's Miser's announcement about this brand new pilot. All right. So let's find out who's joining us today. Let's go to the next slide. And then I'm going to ask Reha Manikandasamy on the MLP team to launch a poll. Give us just a moment. All right. So we'll see that in our icebreaker poll. We first want to know who's joining us. What type of organization are you from? Are you from healthcare, legal services, academia, or an other category? In the second question, tell us, does your organization have a medical legal partnership? Yes, no, or perhaps you don't know, which is okay. Hopefully we're helping you find out. And the third question, so that we can really know a little bit more about the relevant topic for today, that being justice-involved population. How does your organization currently serve justice-involved populations? So are you a health center, a community health center, providing medical services at the health center to justice-involved population? Are you providing medical services through or at a correctional facility? Are you with legal services and providing, or your healthcare and you're providing legal services through a medical legal partnership? Are you in some other category? Or again, which is perfectly all right, do you not know? All right, so we'll leave this open a little while longer so that the majority of attendees today can respond. If you're in the other category, it would be actually great to see in the chat. Go ahead and hit chat to everyone to let us know if you're in any of the other categories, what that might be. All right, so let's just see if we can get 75% participation before closing out the poll. Just a few more people, get folks to respond to our icebreaker poll. And let's go ahead and close it out. Oh, perfect. We're at 70%, 76% participation. All right. So for our speaker's sake and all of the audience, it looks like we have about 39% of you from healthcare, 25% from legal services, 6% from academia, and a lot of people, almost 30% of you, are from the other category. Take a moment and chat and let us know where you're from in terms of organizations. Does your organization have an MLP? 42% of you are saying yes. That's awesome. Some are saying no, about 30% are saying no. We'll get you there. And some aren't sure, about 28%. In the third question, how does your organization serve justice-involved populations? About 14% of you are providing health center-based medical services. About 5% of you, really curious to hear from those folks as well in the chat, are providing correctional facility-based medical services. So feel free to use the chat. Let us know about those correctional facility-based medical services. About 40% of you are ensuring that folks have access to legal services through a medical legal partnership. Some are saying other. Again, I encourage you all to use the chat to let us know what those other services look like. And then 17% are saying no. So hopefully we'll be able to get folks who are in the I don't know category into the at least path to gaining some more knowledge about how they serve these populations and how to better serve these populations. All right. Thank you, Reha. Let's go to the next slide. All right. So it is my absolute pleasure to introduce you to one of our friends and subject matter experts. His name is Dan Mistak. He's an attorney. He's director of healthcare initiatives for justice-involved populations and is a 2023 Atlantic Fellow for Health Equity at the Community-Oriented Correctional Health Services. I want to welcome Dan Mistak, but let me let you all know a little bit more about who he is. So at COACHES, or COCHS, he has led efforts at the federal, state, and local level to improve connections between health and justice systems. He is a leader in the field in creatively leveraging opportunities to use the strength of the health system to help people avoid incarceration. His previous experience has focused on legal issues for underprivileged populations, including representation of clients in asylum hearings, legal research surrounding the Voting Rights Act of 1965, and campaign finance. He previously worked for Legal Aid Society of Hawaii, where he provided support to Hawaii County's behavioral health safety net and its interface with the criminal justice system. While he was there, he also created a medical legal partnership at the local federally qualified health center and worked with justice involved individuals regarding the collateral consequences of their justice system involvement. He also served on the board of NAMI or NAMI Hawaii. He holds a master's degree in genetics and cell biology and philosophy from Washington State University and bachelor's degree in biology and chemistry. Prior to joining Coaches or COCHS, Dan Mistak was a senior editor of the California Law Review at UC Berkeley School of Law, and he's admitted to practice law in California and Hawaii. Dan, thank you so much for joining us today. I'm going to turn it over to you to begin the substantive portion of today's presentation. Thank you, Dan.
Great. Thank you, Bethany, and thank you all for being here and being interested in this topic. And a huge thank you to Reha for getting these slides in order for me. That final formatting is so appreciated. And thanks to everyone at the National Center for Medical Legal Partnerships. I'm incredibly grateful for your continued partnership on these issues and interest in these topics. So on this next slide, that was a very, very warm welcome, but I'll tell the more reality of who I am. The truth is that I am just someone who really cares about figuring out how the heck I can use what I've been given in my life to try and improve the lives of people around me. And that includes not looking away from some of the big policy issues too that require some pretty major changes. All of that, of course, makes me into sort of an optimistic cynic. I'm extremely cynical, but optimistic enough to think that getting out there and doing some of this work can really change a difference, make a difference, not just for me, but for the folks that we're fighting for. And I do that by being a policy nerd. But that being a policy nerd kind of tears me between the micro policy and then the macro policy. And how the heck do I get to do direct services and also keep an eye on the policies that are shaping really how I can do my work? And I really came in and focused on this a lot when I was at the Legal Aid Society of Hawaii, where I was incredibly grateful for the chance to start a medical legal partnership, which I'll talk about in a few moments. But also, we're calling in from Northeastern Ohio, the real heart of the Rust Belt. I moved back here to be closer to family in the midst of COVID and aging parents and all of that. I am the product of Rust Belt, really got those Northeast Ohio values, and I'm really grateful to be able to take my personal and lived experience with my own family and be able to turn that relationship between poverty, incarceration, and health, and really identify ways to try and drive some change. So on the next slide, I'll introduce a little bit about Coaches. So Coaches is a nonprofit that started in 2005 from a grant from the Robert Wood Johnson Foundation. So I've been working with Coaches in some capacity or another for over the last decade. And what we've been trying to do is try and actually bring in healthcare providers in the community inside of the jail in order to try and improve the connections between what happens inside a carceral facility and what happens on the outside. A lot of what happens inside of jails it happens inside of kind of a black box. And in healthcare, we know that by having one provider who sits outside of the broader provider network leads to really worse outcomes, drives up costs, and also makes it so that the people who are receiving care inside of those facilities are receiving less than transparent care without a lot of oversight. So by trying to bring in our community healthcare systems, our original goal was to try and bring FQHCs inside of the jail because they would serve the populations inside and out. We hope that we would improve coverage for people wherever they are, really eliminate some of these barriers to maintaining continuous coverage, both inside and out. And also make sure that we are trying to eliminate some of the significant racial and economic disparities that people face while they're incarcerated. And on the next slide, I took a few years off from, we're not there yet. I'll talk about that in 1 second. So I just wanted to give you all a heads up of what we're going to be going through today. And I know since all of us are probably overeducated and have been through way too many tests, I'm more than happy to give away the answers at the very beginning so no one's too panicked. First thing we want to cover is who's involved with the justice system. And the answer to that is it's way more people than you'd think. In fact, I'd say most of you are probably serving justice-involved populations right now without even knowing it. And if you are knowing about it, then there's some really great opportunities to try and take that knowledge and turn it into meeting their needs that can be pretty unique. And I also want to ask today, what are the health and social outcomes for people involved with the justice system? And as you are probably not surprised to know, it negatively impacts every aspect of their lives, whether it be from healthcare, but also social systems involvement, what happens to their families and family courts, what happens to their kids as they're moving through different types of protective services. And then finally, how can we end up serving the people who are involved in the justice system? And, I don't know, I haven't been to many of your other webinars, but I'm hoping that we can talk a little bit about some of the macro policy changes that are happening right now that'll be really interesting to be able to be deployed to serve justice involved populations, but then also identify some of the very specific needs of people who are involved with the justice system too, in order to try and improve outcomes for them. So on the next slide, I'll talk about the time that I took away from coaches. Everyone in any kind of work needs a sabbatical, but as a person who is, of course, indentured through public service loan forgiveness, my sabbatical had to be a working sabbatical. Never intended it to be a sabbatical. I would have loved to have stayed there for the rest of my life, but federal policy changes called. But I was really grateful for the chance to work at the Legal Aid Society of Hawaii. I was living on the west side of Hawaii and really serving the population there. Fell in love with so many of the people, and also faced every single day the struggles that were faced by people who were there, who were not a part of the wealthy landowning populations, who were really buying up a lot of the property there and seeing the pretty massive changes that were taking place in people's lives. So the MLP that I started at Legal Aid Society of Hawaii was established through some VAWA funds that I didn't get, my executive director got. And so it was originally focused on victims of crime. And of course, coming to Legal Aid Society with my background in coaches, there really isn't the unique. Strangely enough, this may again not surprise you. Involvement with the justice system also really predisposes that somebody would become a victim of crime, either previously or in the future. There's a lot of overlap between and intersectionality between mental health conditions, vulnerability to crime. And so through that grant really expanded the lens to focus explicitly on some justice involved populations there. My MLP was headquartered at the local FQHC. We had a business associates agreement so that I could actually use their electronic health record. Inside of their EHR, I used absolutely minimal notes because wanted to make sure that we were keeping maintaining all of my professional duties as an attorney. But then I would also take my notes in legal server in order to keep track of what was going on legally, but just wanted to also be able to allow for people to schedule inside of the FQHC's scheduler so that I would be able to come in and be able to meet with clients that had called the FQ while I was away. So patients could call the FQ, be given an appointment slot, but also people, I received warm handoffs. If I was not with a client, I had open office hours. And sometimes, quite a few times actually, I was called in to try and meet with someone who just through a screening process or conversation with one of the other providers said, maybe you need to talk to an attorney for a little bit. Absolutely loved the way that I was just grateful for the chance to be there. Loved the model, worked very well for me, worked well for Legal Aid Society of Hawaii. And I also understand that that every MLP is different. And just wanted to make sure that I could throw out here what this MLP looked like. So we're not actually going to talk much about the particular MLP that I was working at. We're going to talk more broadly about sort of what is who is the population that we're talking about here, understanding what their needs are, and then also to talk about some of those policy issues, but happy to answer any of those questions about the MLP if you have it. And I should also say that, I no longer work at Legal Aid Society of Hawaii, but I also would not want them to not receive the credit for all of the support and work that they did to make that a reality. So on the next slide, I think we're going to start diving into, who is involved with the justice system. And as I said earlier, it is already probably a lot of your clients. So on the next slide, I just wanted to cover the current state. That makes me say pretty confidently that there is going to be a significant number of folks that you're already seeing who have been involved with the justice system. As a lot of you know, the United States is the #1 incarcerator in the entire world. We hold 25% of the world's incarcerated population. That is just the incarcerated population. That doesn't include all of the folks who might be underneath some sort of community supervision. So right now, and this is old data, so obviously I don't know the exact number right now, but 2 million people are in some sort of detention. That includes jails, people pre-trial sentenced to a jail, but it also can be prisons where people are sentenced typically for more than a year. There are 10.6 million admissions into jails every single year. When I'm talking about this from the point of view of improving connectivity between health systems, talk about that as 10.6 screenings that happen for people as they're entering into the jail. How do we really maximize those screenings, make sure that we're understanding what people's health needs are as they enter the jail, and then also leveraging that data to be transmitted outside of the jail so that the providers on the outside would know. That's a lot of screenings. The data suggests that 1 in 4 people who were taken to jail will be arrested again within the same year. And often that is the result of how we criminalize poverty, mental illness, substance use disorders. And of course, being arrested again multiple times in that year does not really help their mental health or physical health condition, and often will lead them to be reincarcerated again and again and again. So when we have a system like this, that means, and besides being incarcerated, 7.2 million people right now are on probation, parole, or some other community supervision. Of course, being involved in one of those community supervision programs can mean that an individual is more likely to be remanded back into the system too and incarcerated. So those 7.2 million people are on varying levels of surveillance from the state at some point. Also should note that sometimes those people who are on probation, parole, or community supervision have expectations from their probation or parole official that they be seeking the social, getting the social, meeting with the social services that are supposed to be able to support them. So going and getting housing, going in, trying to get SNAP, and that it can also be that if they don't necessarily connect with those social service providers, that could be a reason for someone to be remanded back into incarceration. So there is a real overlap between someone's social needs and then how they can be remanded back into a carceral facility. So in 2014, all of this meant that about 65 million people in the United States had some sort of criminal record. And of course, 2014 was 10 years ago. So I'd be interested in what that data is now. It's often challenging to get data inside of justice systems. So we can only imagine that number has surely grown since then. So in the next slide, we'll talk about some of the social profile of people who are involved with the justice system. And I think the main takeaway from this slide is, of course, to pay attention to the intersectionality of it, that if you are involved with the justice system, it's more likely that you are poor. It's also more likely that you are a minority of some sort. And so that we can really see that there are ways in which if you are wealthy or if you are white, the chances of you being involved with the justice system decreases. So I often ask people to sort of stop and reflect on maybe what does the function of the justice system actually operate on? Because we can really draw these really interesting demographic data from it. So of course, if you are involved with the justice system, already making less money, when you're coming out, as we'll talk in a bit, you'll have higher rates of unemployment, which of course is a pretty important social need that needs met, unstable housing and or homelessness. And then, of course, you're facing probably lower rates of education and literacy even to begin with. So this is just a way of stacking the deck more and more. And like I said, 1 in 4 people who are arrested in any given year will end up being rearrested at the same year. So in the next slide, we will be able to see too that people who are incarcerated have some pretty significant health needs. This is just looking at the mental health status and substance use disorder status of people who are incarcerated. So I am talking a lot and distinguishing about between jails and prisons. So, and I think that this is a really important distinction to think about too. They do operate very, very differently inside of the criminal legal system. Like I said before, prisons are for people who are sentenced for usually more than a year. California, of course, is different because California needs to be different in order to find its self-validation. But California, of course, has a lot more sentenced people inside of their jails. But suffice it to say that jails where people are staying on average less than 30 days end up having people moving through there with some pretty serious psychological needs, histories of mental health conditions, and only about a third have no indication of mental health challenges. The data, which is you could click on the link that is at the bottom of the slide when you get this. Defines, how is history of mental health problem defined? And I think one of the things to take away from that too is that many of the ways in which we try and define, understand the health profile of people who are involved with the justice system is that we're relying on really poor systems for gathering that data. Not a lot of people get screened historically inside of jails. And so this is just when we see something that says no indication of mental health problem, I think that we should always have one eyebrow up and say, okay, what does no indication mean? Does that mean that we just didn't screen it? On the other slide there, or on the next set of data right there, I want to point out that, of course, people who are sentenced in jails have higher rates of substance use disorder than people who are incarcerated in prisons. So we have a challenge on the front end of jails. People are coming in, have higher rates of mental health needs. They have higher rates of substance use disorder, but also on the reentry side, there are some pretty significant needs that people have. So fewer than 1 in 10 people who are arrested and tested positive for substance use treatment coming in have received any sort of treatment in the previous year before they've entered incarceration. And then as people are leaving, they're much more likely to die of all causes, including heart disease, homicide, suicide, cancer, all accidents. And that the data on that is that people are 12 times more likely to die in the 2 weeks following release from a carceral facility. And they're 120 times more likely to die of an overdose post-release. So we have a pretty serious, what I would say, health transition for people. And much like if you think about when people are leaving a hospital, there are discharge plans, there's things for people to do and follow up on once they're leaving. People leave jails and they have a much higher rate of negative health consequences on the other side. But we aren't doing any of this discharge planning for them. And we'll talk about some of the policy reasons, the macro reasons for that. But that is just something that I wanted to point out so that jails are essentially really working on operating on some of the people who have some of the most acute needs and are the least likely to be able to access care inside of the community. Next slide, please. So this data just came out from the Kaiser Family Foundation, and I just wanted to point out one more time that there are some pretty vast disparities when it comes to who is incarcerated, and we divided this one as looking at it based on race and ethnicity. I didn't include the gender one. This is just the ping that downloaded from the Kaiser Family Foundation table that you could go ahead and find yourself once you get the slides. But of course, our jails and our prisons disproportionately impact Black and brown populations way more than they impact white populations. And so, unsurprisingly, too, these disparities are mirrored inside of our health system. So we have jails and prisons operating on people that are, and I say operating not in like the surgical sense, but sort of more in like a mathematical function sense. But it is operating on the lives of people who are already somehow left out of the health systems inside of the community and really exacerbating the challenges that people face in the community, and they end up incarcerated. And I would suggest that part of that is because that this jails and prisons are where we as a policy through whether it be malign neglect or other reasons, those policies end up being where we hide people, where we do invisibilize some people with some pretty high acuity social and physical health needs. And we put them inside of jails and prisons. It just so happens jails and prisons are deeply disconnected from our broader health systems and oversight systems in the community. And so we shouldn't be surprised that the disparities that exist in the community are exacerbated inside of our jails and prisons. On the next slide, we'll see that also, I think that we can identify that the challenges are actually getting worse. So the Prison Policy Initiative has done a really great job of collecting information on the racial and economic disparities inside of our criminal legal systems. And I should point out that pretrial population. So these are people who have, by the way, never been sentenced to a crime. They are awaiting pending disposition. They're often there because they just cannot afford bail. That we have seen that Black and brown populations have more than doubled in pretrial detention over the last 15 years. So it's a pretty shocking increase. And again, these are people who have not been sentenced to have not been sentenced for any crime yet. They are just awaiting some sort of disposition or release or charges to be even dropped before they before they can return back into the country at large. Okay, next slide. So just wanted to summarize. So this was just, again, to try and hit that first bullet point of understanding who is the justice involved population. And the main thing I wanted to try and do was to maybe begin a little bit of the destigmatization of the process of thinking, oh, this is some different subpopulation. The truth is you're probably already serving many people who are involved with the justice system. And perhaps because of our own lack of screening when people are coming in, or the fact that, maybe even inside of our own mental constructs, we think of people involved with the justice system as different, or that there'd be some sort of, some sort of scarlet letter that they would wear. But the truth is that the way that our justice systems operate, there's a significant portion of our population that are involved with the justice system that we may or may not know about. And of course, when you start including in poverty on top of that, and racial disparities, and the fact that many of our FQs are already serving people who are low income as well, you're probably already serving people who are justice involved. And of course, people who are involved with the justice system have some pretty critical health needs before they enter, while they're incarcerated, and while they're leaving. Already, go over this one more time. The justice system disproportionately impacts poor and people of color. And as we saw from that pretrial detention slide, the challenges are getting worse, not better. So on the next slide, we are going to start going into identifying justice system involvement as a hidden social determinant of health. So what happens when someone is involved with the justice system? We already talked about those, the 12 times more likely to die of all-cause mortality, 120 times more likely to die of an overdose. But that's just on the health, the acute health impacts, but it also impacts families, it impacts children's, it impacts the individual, of course. It impacts the communities where people are over-policed. And in fact, the fact that people, I think, are taken from their communities and brought into justice systems and constantly have this sort of disruption in their life, I think also creates challenges with even being able to organize politically in order to identify what the needs are in your community and to actively advocate for them. So I think that that's one of the things too that the justice system does, is constantly keeps people on their heels so they can't actually stop and assess and collaborate together in order to actually drive political change that's meaningful for their communities. I really deeply do believe that medical legal partnerships and the health system more broadly can help undo some of these health harming collateral consequences about justice system involvement. The main ones I want to talk about are the unemployment barriers, or just keep your eyes on the benefits barriers that people face, the family law consequences that people also face, and then the weaponization of justice system involvement is something I want to also keep our mind on. So the next slide, we will see the way in which being involved with the justice system impacts people's inability to seek employment on the other side of incarceration. So Prison Policy Initiative has done some, again, great work on trying to quantify some of these challenges that should be, I hope, obvious to all of us. But if someone has been incarcerated, there's something that they call the prison penalty, and it more deeply impacts Black women and Black men than it does white men and white women. Not to say that they don't face those impacts at large, but I think it's really interesting. One of the things that we have learned from kind of ban the box initiatives is that even when banning the box, one of the challenges that they face on the other side is that some employers will just opt to just be straight up racist on the other side and exclude people who would have a Black name, which is as the research shows, instead of trying to actually grapple with this. Of course, some of these things are changing too because of the post-COVID need for more labor, and these are, of course, numbers that are from before the pandemic too. The next slide, please. So without a doubt, people who are involved with the justice system who are going through your FQ or going through your MLP are going to have some pretty significant challenges with housing. This is across the board right now where everyone is having challenges with housing. So imagine how compounded that's going to be as people are formally incarcerated. I don't know how the heck we're going to get out of this, because this is such a huge and massive problem across the board inside of cities, more broadly in urban areas, but absolutely want to point out that there are major challenges if someone was incarcerated with finding housing that will accept them. And in fact, some families can't even accept people because of housing limitations on having someone who's formerly incarcerated inside the house. So families are often faced with some pretty challenging choices of, do I allow my ex or my husband or my boyfriend to live with me and possibly lose the housing, or else lose our housing, or else do we have to figure out some other way to make it work? And those are the types of choices I think that end up making families less stable overall, and end up creating people who become more desperate for solutions just because of the policy barriers that we've put in the place of people who are just trying to live and reconnect with their families. So I think the next slide is going to also, I wanted to highlight too that I don't have any actual data about justice system involvement here, but I wanted to point out sort of how I was describing the disparities that exist inside of our health system. There are also racial disparities inside of family court outcomes. The next slide is going to show some data on the Black and Hispanic Native Americans have worse outcomes inside of child welfare systems. There are a lot of historic racist reasons for why this has happened inside of our country. If you have not heard about the history in the United States and in Canada, where Native American populations are separated from children and then trying to force to civilize them, I think that becomes a really important lesson for all of us in seeing that sometimes we try and point to these kind of objective systems. Oh, we got to get kids in the public school system. We've got to do X, Y, and Z. But really, what those things are doing too is taking away and disrupting families and creating a system where you're expecting where our sort of current social and economic expectations end up driving what happens to families. And sometimes that can also result in those families being criminalized because they aren't following what is expected more broadly. I'm sorry if that was very confusing. Happy to try and answer some more questions about that. But on the next slide, let's go over there. And I just wanted to show what these racial outcomes are. So here you'll see what happens. And this is a lot to absorb all at once. But this shows the RDI, which is the racial disparity index that's faced among different racial and ethnic populations. And what you'll see is a racial disparity index above 1 shows that there is more racial disparity. Below 1 shows that people have less disparate outcomes based on what happens, based on this data here. And so you can see that an American Indian Alaska Native has worse outcomes when it comes to having their children placed in foster care, taken away and placed in foster care. You see Black and African Americans 1.6 times more likely to have their children taken away. And then, of course, if we're comparing it to white populations, they have less of a chance of having their children taken away. So I think once we start thinking about, too, the overlay between the racial disparities and then justice system involvement, one of the key things that I think is really scary in all of this, and definitely was something that I came across have come across before when talking to different folks who are working in legal services, is that justice system involvement sometimes is used as a weapon in custody hearings and in custody battles, and that the disparities that exist inside of, I think that we need to be very careful we're not perpetuating some of the ways in which the disparities that exist inside of the justice system are used to further compound the disparities inside of our child welfare systems. So really judiciously understanding the relationship between justice system involvement and whether or not that needs to be deployed when you're zealously defending your client or not is something that I think takes a lot of self-analysis and situational understanding in order to effectively be able to work your way through it. I have no answers for you on that. Just to say that, like, please be aware of that. And that just because someone is involved with the justice system, I think is the knee-jerk reaction to use that sort of information in custody can be really challenging when parents are really trying to reconnect with kids after they have served or else after they have spent their time in a carceral facility. Next slide, please. So just to summarize what this last slide was about, was just to point out that justice system involvement impacts almost every social aspect of someone's life. It isn't just having criminal consequences on the other side, and that these things happen regardless of whether or not someone is convicted or not. So like I said, people are held pre-trial. If they're held pre-trial, they can face the same consequences that people have faced. The 12 times more likely to die, 120 times more likely to die of an overdose, those numbers apply to them, and that's also without ever being sentenced to anything. So on the next slide, I'm going to talk about what can we do with some of this information and understand where can medical legal partnerships make a difference. And we're going to look at this from the macro perspective, and we're going to look at it from a micro perspective too. Like I said, I'm kind of torn between thinking about these things both at the same time. And my hope is that I can weave together and that you all can see that there are some huge and major macro things that are happening that are very, very exciting. And those are going to have major impacts too on the ways that these work the way that these unfold in the micro level too. So on the next slide, I want to talk about something that I call the policy seesaw. That is, I should be blamed for that. I just was calling it the policy seesaw, and I just was like, oh, I'll just smash those together. Um, Not appropriate. So, but I wanted to point out something that's really important because so many of us are working to try and make sure that we can really improve the access to a lot of social welfare for people. And I know that welfare in the United States is often demonized, but I just mean like social spending, federal spending, the state spending that is based on trying to improve people's lives rather than to try and necessarily be uh, uh, used for trying to do surveillance or to try and arrest people or to spend money on carceral facilities. And so Louis Vicomte, in his book Punishing the Poor, which is from 2009, and I highly, highly recommend everyone read that book, he describes a sort of seesaw effect, where what it showed was that investments in punitive policies come during disinvestments in periods of, sorry, investments in punitive policies often come during periods of disinvestment in social services, and then also vice versa. So the more money that ends up being spent on social services ultimately leads in less investment in punitive policies, often because there's less crime that actually happens at that point. I mean, imagine how much less money would be spent on homeless sweeps if we actually had housing for everyone on the other side. But his work isn't the only work that has discovered that. I mean, it's all across the literature. But there was a really interesting study that looked across 18 different quote unquote developed countries, and they showed exactly the same thing, a negative link between the share of national income devoted on the welfare state on one hand and the number of people behind bars on the other. So all the seven nations who had the most incarceration, which was the United States as well, had below average welfare spending, but all but one of the eight countries with the lowest prison population spent atypically heavily on welfare. So there is some sort of magic that happens when if we invest in people's lives, by the output of that is that fewer people end up incarcerated. Now, obviously, I think a lot of us could start thinking about that and understand like very obviously why that might be, but it's really interesting to see inside the literature. And I think that that's something that we should use anytime we're trying to talk to people about why we need to expand more access to social services. I think it's a really important point. So the next slide, please. So I have a hypothesis that goes along with this, that if we expand access to public goods, we'll shrink our spending on the carceral system, but there's very few vehicles anymore in this country since the 80s for entitlement programs, except for one, which is Medicaid. Next slide, please. So the reason why Medicaid is so important is because Medicaid is incredibly flexible. So now I'm talking about this at the macro level. Medicaid is incredibly flexible. Each state has their own Medicaid plan. And Medicaid now increasingly is paying more and more for really important health-related social needs supports for people. And it's happening through something called a Medicaid 1115 waiver, which I'll talk about more in a bit. But Medicaid allows for a lot of flexibility in order to create funding for innovative initiatives like MLPs is my big sell on this. But what it does is requires sort of you all understanding the Medicaid waiver process, being able to communicate effectively with health policy folks, and then also recognizing your own value to health professionals. And what I say is if MLPs can learn to work with Medicaid, then MLPs can go where Medicaid goes. And the next slide talks about why that is so important for us to hitch our wagon to that star. And that is because Medicaid really has played a limited role inside of our justice systems, but that role is evolving. So before 2014, most people involved with the justice system did not have access to any sort of health insurance. But since 2014, states that have expanded Medicaid for the first time ever are able to really provide care for the people in the community who would ultimately end up being justice involved. So with the expansion, the eligibility criteria changing for people involved with the justice system so that they can actually access Medicaid based on their income, we now can reach far more people in the community who, as we mentioned earlier, have some pretty critical unmet health needs. And so my hypothesis that is presently in the being tested is that if we can really expand access to people's so that they can receive the care in the community that they need, we'll see fewer people being involved with the justice system. But there is one major challenge that we still have to overcome in this process, which we'll talk about on the next slide. That is something called the inmate exclusion policy. So I did not come up with that term. That was one that's kind of baked into the 1965 Social Security Act. So I think that this is really important to understand too, because this is a policy that is currently being changed and being reflected on by the federal government and by different states. So because of the way that Medicaid was written in 1965, people who were incarcerated in what's called who are inmates of a public institution, although they may be Medicaid eligible, they may have met all the eligibility criteria, they are not able to receive Medicaid benefits except for 24-hour inpatient hospitalizations. So what this means is that you can actually be receiving care in the community. The moment you're booked into a jail, again, pre-trial, never been convicted of anything, you lose access to your Medicaid services. So if you were receiving substance use treatment in the community, then you no longer actually are able to receive that from that same payer anymore. And of course, this is going to really shift now where the expenditures are going to come from for those services down to the local level, because most jails are county run. So now we're creating this sort of shadow health system that is going to be trying to meet the needs of some of the most critically at need people, and then have that care be completely disconnected from the broader community. And then we release people out into the community after they've served their time. And we have to wonder, well, why do 1 in 4 people end up back being incarcerated? So that's sort of the macro level at that. I should point out that what this inmate exclusion does is it creates a micro effect where people leave jails and leave prisons without Social Security and Medicaid, because many states often will just knock people off their rolls or else will suspend their Medicaid, which means they have to jump through bureaucratic hoops to get their Medicaid turned back on, and face some pretty severe challenges in doing that, while they're also trying to, not become one of those people who are 12 times more likely to die of all causes after they've been released. So how is this changing? The next slide talks about the way that the federal government now is allowing and inviting states to create what are called Medicaid 1115 waivers in order to actually waive that inmate exclusion. So, like I said, every state has their own Medicaid policy, but the Social Security Act, which created Medicaid, has within it what are called Section 1115 waivers. And they allow for states to ask the federal government to waive certain components of the Medicaid statutes so that they can better meet the needs of the folks inside of their state. So in April 17th of 2023, for the first time ever, the federal government said, okay, states, you are more than welcome to actually create a waiver that is going to waive part of the inmate exclusion. But you can waive up to 90 days pre-release, both jails and prisons or juvenile justice facilities or reentry centers. And any of that, we will actually cover anything that you ask for and that we decide to approve, but it must at least include medication-assisted therapy, 30 days of bridge medication, and case management. These waivers will happen state by state, and rollout is going to be slow. But this is something very exciting that's happening. And like I said, if Medicaid can start going into these places and you have started figuring out how to hitch your wagon to the Medicaid star, it's a really great opportunity for you to be able to also follow those healthcare providers, those community healthcare providers inside of the jails too. Next slide, please. Just wanted to cover these, required benefits and highlight that health-related social needs component of it. And the reason for that is because I really think MLPs could play a major role in being being a service provider for people with health-related social needs. So many different Medicaid waivers right now are being approved in order to try and create housing stability, in order to just try and meet a variety of people's health-related social needs. And I think that there's a really great opportunity there for MLPs to pitch to their state why and how they are actually meeting people's health-related social needs and the type of value that you could offer to a state Medicaid system to improve care for people who are involved with the justice system. Let's go ahead to the next slide too. So I wanted to point out some more micro opportunities now. So that big macro component of this, happy to answer more questions about that too at the end. I just want to make sure I get to the end because I am I'm running short on time here. But just wanted to point out that people involved with your justice system will have needs just like any of your other clients. Highlighting in particular family law and custody issues are incredibly important. And I know how much legal aid and legal services can be really important for kind of diffusing some pretty challenging family situations. So I know that that's something that's really important, especially as people are leaving incarceration and trying to figure out if they even fit inside of their families anymore. But besides that, there are some pretty special areas of interest that I, of course, want to flag your interest in. Can't go into how all these things can be dealt with, but want to talk about, of course, expungement is something that's really important. And I should highlight that Kentucky, some of them, 4 of the managed care organizations there will actually reimburse beneficiaries of an MC, of a managed care organization, for expungement. So if they're paying for an expungement, they can actually be reimbursed for that. So I think that's a really great opportunity too, to figure out how to operate with managed care organizations to try and partner with them in order to do things like expungements. There's also a significant amount of housing discrimination. Want to definitely flag health privacy issues. That could be a huge part of this. And make sure that discontinuation of services and benefits is on your radar too, because of things like that. Inmate exclusion means that people can lose access to Medicaid, but also access to Social Security as well. But as more as these Justice System 1115 waivers are passed, I want to highlight a really important new area of advocacy. And I think that's going to be the denial of Medicaid benefits despite a waiver being in place. And what that means is we know that the LSC funding doesn't let you challenge the conditions of confinement, but it doesn't say anything about you being able to try and make sure. And of course, I'm not completely up to date on LSC, so this is not legal advice, of course. But the denial of benefits, when someone is incarcerated now, if they are a beneficiary and there's a waiver in place and they are supposed to have access to certain services, I think we really need to be on the lookout for making sure that that individual receives the services that they're supposed to as a beneficiary of that waiver. And I think time will tell what that will actually look like in practice. Next slide, please. Great. So just to recap, people involved with the justice system have serious unmet needs, and health and justice system disparities compound one another. There are new funding opportunities through flexible Medicaid waivers to support people's health-related social needs. Also want to point out that HRSA is also changing its rules around where and how FQHCs can provide services through a new PIN, a policy information notice. Be happy to share with you about that. Have a look at that as well. One thing I want to highlight that I think that this is a huge step in the right direction, but one of the main challenges of this PIN is that it does not allow for FQHCs to provide services to people who are pre-trial, which, as we focused on, is actually a significant number of people. And then finally, understanding and working with Medicaid can unlock new funding. And as Medicaid's reach extends, which is happening currently, MLPs can hopefully ride that wave. Okay, next slide. And I think that's it for me. Great.
Excellent, Dan. Thank you so much. I'm gonna come back on camera. Perfect. Thank you, Reha. The audience was fully attentive throughout the entire duration, Dan. And so I just want to ask folks if they had questions. I think someone may have had a question. I don't know if they're still there, but I believe someone in the audience named Patricia had a question. Patricia, if you still have your question and you want to place it in the chat, I can also attempt to unmute you. Um, the first question that came in via the Q&A, Dan, is have any states successfully funded MLPs through Medicaid 1115 waivers? I assume that's what the individual means by waivers.
Yeah, so I would say not that I know of right now. And I think that the part of that too is because there's really a lot of I think that we're all really great at making sure that our clients get access to their benefits, but when it comes to sort of this macro level understanding of how the Medicaid system works, things like the 1115 waiver process is just not necessarily on our radar. There's a lot of really great opportunities to, first of all, improve relationships with your state Medicaid agency in order to have some of these conversations about that. But then to also understand the new opportunities through the HRSN opportunities that have been opened up during the Biden administration and some of the waivers that have been approved. So I will say that there are different states that are looking at the waivers that have already been approved and trying to identify different buckets that they could fit into. The community supports bucket inside of the Cal AIM initiative is one that I know that we were looking at together before. But I would not say that that has definitely not explicitly been mentioned by by that waiver. There are other different buckets that you can try and identify and pull funding from. But again, that does require some new coordination with MCOs, state Medicaid agencies in a completely different way than we might have before.
Yeah, it's a very nuanced question. So if the individual is asking about having an MLP fully funded by a Medicaid waiver, remember you are asking a state to ask CMS for approval for specific types of your MLP services to be perhaps funded via a waiver. Maybe screenings may have been approved, and those screenings include screenings for legal needs that might be present. So if that's what the individual is asking about, we have seen those examples. So it's important to look at the depth and breadth of services that are provided by an MLP, all of the operations and functions that go into MLP, and then trying to align it with what might be able to fit within the Medicaid or Medicaid waiver bucket, or as Dan mentioned throughout the presentation, what an MCO might be willing to tap into their administrative dollars or otherwise to support with funding. So pretty nuanced question. Folks may want to absolutely take a look at California, the Cal AIM waiver, as well as the previous 1115 waiver. North Carolina is another great example that has continued to move along progressively in this space for limited services within the MLP being supported under the Medicaid waiver. But we're still far too limited for our satisfaction in the MLP space. Appreciate that question. Let me see if anything else came through via the chat. Dan, I think, let me just double check the Q&A again. All right. Okay. So no other questions have come through via the chat or Q&A, but I want to sincerely thank everyone for joining us today. And a lot of folks were privately messaging us to let us know that they really appreciated the content, which will be shared on the National Center for Medical Legal website. So Dan, thank you so much for continuing to share important information that is very well timed for folks to take advantage of the opportunities that are present for, speaking of funding, the HRSA funding opportunity specifically for health centers working with this patient population. In the slide deck that will be shared, folks will also see that we have shared as a resource a web page that hosts coaches weekly update about the HRSA draft pin, the 2024-05 pin that proposes policy guidance regarding services to support transitions in care for justice involved populations reentering the community. Coaches also has a weekly email that goes out, I believe, Dan, that folks can subscribe to so that they can stay abreast of updates. Thank you. Dan's nodding yes. So I would encourage folks to sign up for that weekly update from coaches as well. If anyone has additional questions, Reha has plugged a link to our SurveyMonkey And you all are encouraged to not just fill that out, but let us know what additional resources you may need to ensure that you can develop medical legal partnerships or implement MLP strategies to best serve these populations, or take advantage of opportunities to weigh in both at the macro and micro level and changes that would support serving these populations in the communities. As Dan mentioned, this is not a specific population that you probably have to go out and search and find. You're very likely already serving these individuals and can better serve their needs if you implement some of these broader community-based strategies. So again, thank you everyone for joining us today, and another thank you to Dan Mistak of COACHIT for presenting this very important information. Fill out our survey, and we will see you all on additional National Center for Medical Legal Partnership events. Have a great day, everyone. Take care.